The question often comes up, what percentage of patients are refractory or relapse after standard frontline therapy? And depending on the risk category, this can be as high as 30-35% of patients who initially respond to R-CHOP and then relapse, or are primary refractory. Primary refractory disease is fairly rare, probably less than 5% of cases, but it does occur, and it typically results or is manifest by positive PET scan or progressive disease during primary therapy with R-CHOP. The more common scenario, which can occur in up to a third of cases, is relapse after achieving a remission, and usually those relapses occur in the first year or two after completion of primary therapy.
Well, the patient relapse refractory large cell lymphoma, as I mentioned, these patients can receive salvage chemotherapy and then high-dose therapy and transplant. The question is that you alluded to is that who can qualify for this? Well, the patient who are in first relapse and have chemosensitive disease, and the better chemosensitive, the more chemosensitive, the better. Reaching a PET negative prior to high-dose therapy and transplant clearly has an impact. The issue here is that some of these patients are not great candidates for transplant high-dose therapy, but also some of these patients do not respond well to the second line. And the primary refractory patient or the early relapse do very poorly in that setting. So this is not something that we actually recommend necessarily. And I think that when you look at the overall experience in a patient in the R-chemo era, the outcome of patient after high-dose therapy and autologous stem cell transplantation is still only in the range of 10-15% of the patient that you save in the long run. So this is not the perfect option at this point, but thankfully we have other options we'll talk about, including cell therapy in a minute. So the patients who are ineligible for transplantation, these patients are really an unmet need, and similarly to the patient who fail after transplantation, as you said. So there's some option now. So we'll talk about CAR-T and cell therapy in a minute, but in maybe easier to use that polatuzumab data referred to, the BR plus minus pola was very impressive, and it's now approved, and then it was 40 patients per arm. But what was impressive is that the CR, which was the primary endpoint, was 40% versus 15%, and with a very significant difference in duration of response and survival. So this is interesting. The R-square ibrutinib is something that we presented updated at ASH in a non-GC subtype. It's important because as we go with age, up to 2/3 of the patients in elderly patients over 70 and above can be ABC or non-GC subtype. So this is really one of the unmet needs that we alluded to before, right? So these patients R-square ibrutinib, during the chemo-free part, we had a response rate of 86%, and the response rate was 60%, and then some very durable response. We have patients who are well over 3 years with the disease control with R-square ibrutinib in a non-GC, particularly non-GC diffuse large cell lymphoma. So I think this is something to keep in mind. And finally, the L-MIND data, which is lenalidomide plus anti-CD19 tafasitamab, and the response rate in this situation was very impressive and very durable response. So this is really potentially an option, and that is being now combined in a frontline setting in the context of BR polar or bendamustine, Gazyva and polar. So trying to integrate these novel therapy in a frontline setting. And in a patient who are not candidate for transplant, this is really, again, an unmet need. Those are perfect candidates for clinical trials. And we'll talk a little bit more in a minute about cell therapy in that setting. But in reality, the patients who are truly not eligible for autologous stem cell transplant because of frailty or comorbidities are not going to be necessarily great candidate for CAR-T cell, at least at this point.
So describe your experience with R-CHOP on patients who relapse. What's the typical response and duration of response after R-CHOP? This is a challenging question, and it all depends on where you get the data. So if we talk about outcomes in real life, you know, the R-CHOP outcomes are worse, as opposed to in clinical trials, in which there is an inherent selection bias. So we tend to select the healthier and less sick patients on trials, so they will probably tolerate better the treatment and they will complete the treatment. So, and also patients will have less aggressive disease. So in general, what I see in my general practice is about 60 to 70% of patients are cured with R-CHOP. The rest, 30-40% patients will either relapse or remain refractory. In terms of long-term remission, probably the most important data that we have is from the HELA study, the French study of the compare R-CHOP versus CHOP, that showed that about 50% patients were still alive at 10 years follow-up.